Good morning, Facebook. Michelle Quesada here with WPTV, and I am with Dr. Olayemi Osiemi today. We're talking with the infectious disease specialist at Triple O Medical Services. Dr. Osiemi, thank you so much for joining us. I know you're down in Miami at a convention, so taking time out of your day to talk with us today about treatments for COVID-19. So thank you so much.
Thank you for having me.
Absolutely. And for all of you who will be joining us and watching, feel free to ask questions. Today, we're talking about what kind of COVID-19 treatments hospitals in our area in Palm Beach County are using for those who show up with symptoms for COVID-19, moderate to severe. And so, starting off, Dr. Osiemi, if you can just kind of talk to us a little bit about what is one of the first things that you do when someone shows up to the hospital, the emergency department showing COVID-19 symptoms and, they're asking for treatment?
All right, the first thing we do is try to confirm a diagnosis. Once the diagnosis has been confirmed, we need to know if that patient has any risk factors that can make him susceptible to severe disease. We also need to know how much oxygenation do they have. If someone has low oxygen level, meaning less than 94%, that individual is more at risk of developing worsening symptoms. So we have a criteria to determine who gets admitted or not.
And at that point, I know that the governor has set up several monoclonal antibody therapy centers across the state. Those are for people who can do that as an outpatient option. But do they have to be at a certain point in their illness to be able to qualify, to be eligible to do that? What is your medical expertise on that?
That's a great question. Yes. So once patients arrive in the emergency room, if their oxygenation is at least 94% and above, and they don't look dehydrated, they're not having tachycardia, meaning their heart rate is very fast, those patients can be referred to get monoclonal antibody. Sometimes the emergency room can give monoclonal antibody, but they are not equipped to take care of a lot of patients. So they would then refer those patients out to places where they are given monoclonal antibodies.
And what does that therapy look like? Is that intravenous, or can you get a shot? How does that work?
So monoclonal antibody tends to be given through intravenous route. For people who are exposed to individuals who have COVID-19, those patients can be given monoclonal antibody subcutaneously under the skin. But people who actually have the disease tend to be given through the IV.
Now, I know that, obviously the type of treatment protocol that you get at the hospital, if you are admitted in because you have severe illness, can vary hospital to hospital, can also vary depending on your own medical history and what your underlying conditions are. For you personally, you're affiliated with JFK North, with St. Mary's, Good Sam. What are some of the protocols in place that are options for people if they are admitted? What are some of the drugs that you would try to prescribe at that point?
Yeah, the standard of care when you get admitted includes steroid, dexamethasone, remdesivir, which is an antivirus. Sometimes we use medication that slows down the inflammatory response. One of such drug is called baricitinib. So ideally, everybody that comes in who has low oxygen gets the decadron and the remdesivir. Sometimes we add plasma to it. Plasma is almost like the monoclonal antibody that we get from people who recover from COVID already. So
I'm glad you brought up the plasma, because from what I understand, some hospitals aren't even giving the convalescent plasma anymore. Some are still using it as a tool to be able to fight COVID. Why is that varies depending on the hospital you go to?
Because the data, from what we know so far, from our experience, from all the research that's been done, the plasma can be effective in some scenario, but not always. But the standard of care is to give the steroid and the remdesivir right away, and then consider the baricitinib to decrease the inflammation. That's typically the scenario. But what happens sometimes is there might be a reason why we cannot give a drug. such as remdesivir. If you have bad kidney failure, you can't give that drug. If you have kidney failure or liver problem, we can't give remdesivir. If you have kidney problems, we can't give baricitinib. So that may limit what drugs we can give you.
Interesting. And someone on the comments mentioned, Warren mentioned ivermectin. Is that something that is being used at all in the hospital setting?
Not at all. We don't use ivermectin in the hospital because there's no data suggesting its efficacy in people who are admitted to the hospital.
And in what cases I know some private practitioners are prescribing ivermectin. There have been some people who have said that they have seen results. I don't know what the studies show on ivermectin. If you can kind of give us a little background on how it was used before, because I know ivermectin and hydroxychloroquine were two that were kind of used at the beginning of the pandemic and then sort of got discontinued throughout it.
Yeah, at the beginning of the pandemic, we didn't really have a whole lot of choices of treatment. We didn't really have a lot of data on what the best practice should be. So we used hydroxychloroquine, we used ivermectin, we used pretty much a lot of things. But over time, with research and data collection, we realized what worked and what didn't work. So hydroxychloroquine, for example, is not something we use anymore because it hasn't been shown to be effective. Ivermectin is another drug that we've looked at, and it really hasn't been shown to be, effective. These drugs have activity against the virus, but they're just not enough drug can give somebody to make it clinically worth what the efficacy. So it's not something that I use. Vaccine is still a better option to prevent COVID infection. Once you get the disease itself, a better option would be monoclonal antibody because we know those work.
And at this point, doctor, all of these drugs that you have mentioned so far, the steroids, the remdesivir, the convalescent plasma therapy, all of that has just been situations where this has been repurposed to fight COVID, except for remdesivir, right? That's the only one that was kind of developed specifically for COVID-19.
Yes, the remdesivir was actually designed for a different disease process, and then they kind of looked at it at the efficacy against COVID-19, and they realized there was some benefit. A lot of the treatment that's out there, yes, they're basically drugs that are being used for something else, and they just kind of look at the efficacy in COVID-19 infections.
Right now, is there one combination in the hospital that seems to be more successful than others, or is it just kind of, throwing everything at the wall and see how the person responds?
I mean, pretty much everybody gets Decadron and remdesivir when it comes in. If there's no contraindication for it, then the baricitinib may be added if we think somebody is really going towards the point where he may be very severely ill.
We have a question from Francine. Doctor, I'm not sure if you may or may not be able to answer because obviously you don't work at these monoclonal therapy centers, but maybe you have some knowledge of what they're doing. She said she got the 4 shots subcutaneously, what do you call it? Monoclonal antibodies. And she said that she didn't get any type of information that shows that she got it. So how can she prove that since she has to wait 3 months to get the vaccine, the 90 days the CDC recommends to get the vaccine after getting the monoclonal antibodies? Do you know if there's any type of way to show proof that you received that treatment?
Typically, there should be a piece of documentation that's given to a patient that talks about the reason, the drug, why you're getting it, what it's used for. And the provider can also give her a piece of prescription or a letter saying that she received that treatment.
Okay. And, speaking about some of the other drugs that we've seen, the Ivermectin, the hydroxychloroquine, are you seeing that any practitioners are still in a private setting out of the hospital are still prescribing these?
Oh, absolutely. We still see it. And I have to mention that patients who have lupus, some of them are taking hydroxychloroquine, but they still end up in a hospital with COVID. That means that drug is not preventing the COVID infection. So, there are doctors out there will still prescribing ivermectin and hydroxychloroquine, and we see some of these patients come in after they develop infection.
Melissa is asking, she says she's had family members that received the COVID-19 vaccine and are still getting COVID. She says, why do you say the vaccine is the only method to prevent it?
Okay, that's a great question. So the goal of the vaccine is actually to decrease your chance of getting severe COVID infection or develop infection bad enough that you end up in the hospital. So you can still get infected with COVID after the vaccine. The goal is just to prevent you from getting bad infection.
And I just want to clarify something because I saw a comment on here from Jamie, why would you need treatment before getting the vaccine? Jamie, we're specifically talking about people who are COVID positive, who go to the hospital and need COVID-19 treatment. So these are the options that we're looking at. What is available in the hospital setting? What is available outpatient? And Dr. Osiemi, at this point, is the monoclonal antibody the only outpatient treatment or therapy right now for COVID-19?
That's the only one available right now. There are other forms of treatment that are currently in clinical trial that are not approved yet, but there will be other options.
And, I know there's been a lot of buzz out there about, when will we see something commercialized like Tamiflu for COVID-19? Are there any studies going on or any trials going on for something like that?
Yeah, there are some oral medication that are currently in clinical trial. There are some intramuscular injection that have good promises. So there will be other options in the near future.
We also had a question. I'm trying to find it now. It was a very good question. Oh, Kelly. Kelly Stoles is asking, what effects do any of these treatments have on the liver? And I think you touched on that a little bit with remdesivir.
Yeah, so with remdesivir, for example, if you come in with normal liver function and we put you on that drug, we do monitor your liver function. So if it appears that it's getting worse, we'll stop the drug, and usually people will recover. If you come in with abnormal liver function that's over 10 times the normal limit, we won't even put you on that drug. So there are safety labs that we look at before and during treatment.
Jamie's asking, she's asking about the woman who commented on receiving the 4 shots. So that Jamie was a viewer who commented about getting the monoclonal antibody therapy. So if you have COVID-19, Dr. Osiemi said, if you are not admitted to the hospital, if you have not progressed to severe illness, that you may be a candidate to do the monoclonal antibody treatment, which is outpatient. And that could be said, Dr. Osiemi, that could be the subcutaneous shots that you talked about, which is 4 shots, or the intravenous IV method.
Yeah, if you do have the infection, the disease, we tend to give intravenous. However, if you have trouble finding a vein, we could do a subcutaneous injection. But the subcutaneous injection is usually reserved for people who are exposed to an individual who has COVID, maybe live in the same household.
Any other type of medical conditions that could cause you to have to tailor your treatment for COVID-19 should you be positive and have to go to the hospital? Is there any type of reason why someone might not get, for instance, convalescent plasma or, any of the other steroids that you mentioned?
The steroid is, almost everyone can get a steroid. In patients who have diabetes, it may increase the blood sugar, but we can always manage that. The remdesivir, there are indications.
Oh, sorry, we lost you there for a second. You got muted for a second.
Can you hear me now?
Yeah, we can hear you now.
Yeah, so there's some situation where remdesivir is contraindicated. Someone who's on dialysis, who have bad kidney disease, someone who's bad liver disease, and basiritinib is also the same thing. If you have bad kidney disease, we can't give you that drug. So there are only limited situations where we can give some of these drugs. Other than that, most people are able to get it.
Annette brings up a very good point. She says Regeneron, which is the monoclonal antibody therapy that we keep hearing about, is not a substitute for vaccination. Can you talk about the difference, Dr. Osami, between getting the vaccine and the antibodies you create and how long they last versus getting monoclonal antibody therapy because you have been exposed to COVID or now you're COVID positive?
Yes. So first of all, Regeneron is not the only company that makes monoclonal antibody. There are other companies like Eli Lilly, GSK that makes the same product. The vaccine is really what you want to get before you become infected. Usually takes several weeks for it to be effective. So if you took Moderna vaccine, it takes 2 weeks after the second dose before it's protective. Similarly with Pfizer vaccine, 2 weeks after your second dose. So you want to go with that. You want to get that way before you're exposed. But if you haven't been vaccinated and you get exposed, getting the vaccine at that time is not going to be protective because it takes about 6 weeks. So in that scenario, you will get monoclonal antibody to prevent you from or reduce your chance of developing disease. If you do become infected, then you have to think about monoclonal antibody to treat you so you don't progress to a point where you end up in the hospital. So that's the differences. Those are the differences.
And what is the difference between how long the antibodies last? Because we know that the CDC doesn't recommend you getting the vaccine if you've had monoclonal antibody. They recommend you wait the 90 days. Is that how long they expect those monoclonal antibodies to last in your body?
Yeah, so during the clinical trials that we did, when you give somebody monoclonal antibody, they are unlikely to develop COVID infection up to 90 days. So we know that. So we recommend people not to get the vaccine during those 90 days. And the second reason is that if you get the vaccine within those 90 days, it's conceivable that the monoclonal antibody could affect the response to the vaccine. So we want to wait 90 days when the monoclonal antibody is no longer around, that we can respond well to the vaccine. And we do also know that you're going to be protected anyway during those 90 days.
I also want to ask you, because there's a lot of questions about what's emergency use authorization, what's fully FDA approved. We know now the Pfizer vaccine is fully FDA approved. Monoclonal antibody treatment, the one that we're seeing at these therapy centers, is that fully approved or is that emergency use authorization? Where does it lie in that approval process?
That's also an emergency authorization use. That also should be getting full approval at some point shortly. These drugs are emergently approved, authorized, so to speak, because we are in a pandemic. And to get drugs approved, it takes months of paperwork, reviewing the data, looking at safety, and all those kind of things. So when you give emergency authorization, FDA have to work very quickly to review all those data, but they still have to go through the formal process to get the full authorization.
Dr. Becky has a good question. Becky Beckman, if asymptomatic, do you still recommend getting the monoclonal antibody if you're positive with COVID-19 but you're asymptomatic?
There's no need for treatment if you have no symptoms.
Okay. Someone also brought up that they had a relative who was prescribed antibiotics and they got a lot better. Have you seen that antibiotics are playing any role in this? I mean, I know normally they're used to treat bacterial infections, not viruses, but is that being prescribed in the hospital setting or private practice setting?
That's a great question. You're right. The antibacterial drugs have no activity against viruses. However, what happens most providers feel like if you have a pneumonia, you need to get antibiotics, but viruses can cause pneumonia, and antibiotics have no role in that. Having said that, someone could develop a viral infection and then become susceptible to a bacterial infection, but that's not very common. So a lot of times antibiotics are prescribed when patients really do not need the drug. Most viruses, you're going to get better on your own anyway. So giving you antibiotics in a disease that you may get better doesn't necessarily mean the antibiotics did anything for you.
Yeah, that was Madeline's comment. You see it up there on the screen now. She was talking about her grandson having COVID and getting the antibiotics, and he was up the next day. His taste and smell was back. I don't know what the medical history is there, but No Soon also had a similar comment. He said, I took a Z-Pack, prednisone, zinc, vitamin D, Kenalog, and then I took another treatment of prednisone, and he took CBD. Apparently, he said he was fine the next day after taking lots of vitamins. I don't know if he went to the hospital or not. Just reading the comments. Is there
Yeah,
any?
in a
Yeah.
mild disease, you're gonna get better on your own anyway. And if you take vitamins and all the things, but the antibiotics usually do not work within 24 hours. So if they got better, they got better because one, they were gonna get better anyway, or they got better because of the steroid and the other vitamins they took.
There was also a question about how long someone should wait after getting infected with COVID-19 to get the vaccine. Is there any new data on, what is a good time to get the vaccine after infection?
Once the individual has recovered from the disease, they can get the vaccine, and that usually takes about 2 weeks.
Doctor, is there anything that you would recommend your patients if they tested positive for COVID-19, are feeling sick enough to have to go to the hospital? Any type of treatment they should be asking about when they get to the hospital if they have low oxygen levels or serious cough? What should they be asking? What kind of questions should they be asking the hospital staff?
I think the first thing people need to realize is once you diagnosed with COVID or you're thinking of COVID, you need to think about the severity of your symptoms and also think about what medical problems you may have that may put you at risk for severe illness, such as diabetes, hypertension, lung disease like COPD. If you have any of those comorbidities or you have a severe infection, you should not wait. You should not sit at home and try to quarantine yourself. You should seek some medical help. Once you get to the hospital, all the hospitals have the same standard protocol. They're all going to give you steroid if your oxygen is low. They are going to give you remdesivir if there's no contraindication, and they're going to give you anti-cytokine drug if there's no contraindication. The main thing is if you think you have severe symptoms, don't wait, because monoclonal antibody works if given within the first 7 to 10 days of your symptoms. So there are people who waited 2 weeks and then they come by. The drugs will not work at that point, and then they didn't get the opportunity to get treatment. So don't wait. Seek help. There are treatment outpatients that you can get to prevent you from going to the hospital.
Doctor, why is it still recommended to get the vaccine if you got COVID-19 and you did the monoclonal antibody therapy? Why is it still recommended to get the vaccine after that?
Okay, these are two-part question. So if you get monoclonal antibody, that's only protective for 90 days. So you need to get the vaccine after that. If you have natural infection, you tend to have an infection due to one strain. As you know, there are multiple strains out there. Now we're dealing with Delta strain. So we do know that people who had COVID infection, if they do receive the vaccine does give them coverage against different strains. So it's beneficial to get the vaccine than not to.
Doctor, I know there are tons of comments coming in about how the hospitals are overwhelmed. We know Palm Beach County just put up a dashboard today showing our hospital bed use, and we're at negative 10% in the county. Obviously, very serious to see the hospitals fill up with so many COVID patients. If I know you said no one should avoid going to the hospital if they're feeling very ill. If they're at the beginning stages of COVID, is there anything naturally that they can do or anything they can take to try to avoid progressing to the point where they have serious symptoms? And of course, this is not taken into account if they have underlying condition, which you mentioned at that point. Monoclonal antibody is probably the best way to go.
I think once someone become infected, the first thing you do is call your primary care doctor and get some advice on what to do next. Obviously, increase your fluid intake, take vitamin C, vitamin D, so you can do all those things. But again, contact your primary care doctor to at least let them assess you to see if there's anything else you need to be getting, apart from the vitamin C and D and zinc.
And I just want to address a comment on here. Valerie is saying most COVID patients in hospitals that took the vaccines, that is incorrect information. We have received tons of information from our local hospitals who always say over 80 to 90% of the patients are unvaccinated. Doctor, have you received any data recently or any patients' information recently that show otherwise?
No, yeah, majority of people we see in the hospital are unvaccinated. Yes, it's about 90% or even higher uh, of people we see in the hospital.
For those who do have the vaccine breakthrough infections, because we know that people are getting sick even with the vaccine, are you seeing them in the hospital? What is the type of disease that they're facing when they go to the hospital?
Yeah, so we do see the people we see that have gotten the vaccine are two groups of people. We see one group that only receive one dose of the vaccine, and those patients are not protected, are not well protected. And then you have people who had the two doses, who may have had it several months ago. So because what happens is the titer does drop over time, and that's why we are recommending to get a booster. So those are the two groups you see.
I just want to touch on the monoclonal one more time because we've had so many questions about it. I know we have people joining in the conversation, and thank you all for commenting and asking questions. Just to kind of give a recap, Dr. Osiemi, what is the monoclonal therapy, and kind of tell us, where did this come about? Was this something that has existed before and was repurposed for COVID, or is this something new?
Yeah, monoclonal antibody is something that's not new. We've been using for years. So in this particular disease, what we did was basically design a drug, an antibody that will block the virus, the spike protein from binding the cell. So that's something we've been using for years and years in medicine.
Anyone, I know that we've had questions about ivermectin as well. Is there any situation in the hospital setting, Dr. Osimi, I know you mentioned that that's not being used because of studies that show it wasn't as effective as we thought it would be at the beginning of the pandemic. Any scenario where you would prescribe that just to, obviously I talked to a doctor yesterday who said that they do prescribe it if the patient is asking for it, just kind of to give them hope that we're giving you everything that we have available to us. Is there any scenarios where you have done that as well?
No, I mean, there are patients that will come in asking for it, but you have to keep in mind, just because somebody asks for it doesn't mean that it works. And so our goal is do no harm to patients. So if there's no data suggesting using ivermectin in a patient who is severely ill, why would I want to give that drug? So because all these drugs have a potential side effect, and so they have interaction. So I tend to explain to patients when they request for a treatment that I don't think is effective or has no data that shows effective, I will explain to them why I don't think it's effective. And so I think once you explain to people, they tend to understand. Some people still insist, but it's almost like a mom going to pediatrician and saying, I want antibiotics. My daughter is sick, and the doctor says your daughter has a virus infection. You don't need antibiotics. And the mom still insists on getting antibiotics, and you give it. So I don't think we should be doing that.
Can you explain what is ivermectin and what scenarios is it used? Because I know there's been a lot of information in the news recently about how ivermectin is used on both humans and animals, and what kind of doses can be very toxic for humans.
Yeah, we use ivermectin for parasites. So parasitic infection, that's where we use ivermectin for. Again, like I said before, the dose of the ivermectin, I mean, in the test tube, it appears that it does have activity against COVID-19. However, if you need to give enough drug to be effective inside a human person, you just can't achieve that level. It will be toxic.
You're saying that the level in which you see antiviral properties of ivermectin is too high, too toxic for humans.
Correct. I mean, if you look at other HIV medications like Calitra, we used the drug early in the pandemic because we knew inside a test tube it does work, but we can't give enough dose to people to make it work in humans. You need about 10 times the dose we normally use it right now, which would be very toxic.
Anything else you'd like to add, Doctor? And I appreciate everyone who has brought up great points. People have asked questions. People who have, questioned or doubted what we're talking about, and we get to talk about it and clarify it. I appreciate all of the comments. Doctor, anything else you'd like to add? Obviously, I know the idea, the best way is to keep yourself out of the hospital, right? Stay healthy and try to stay out of the hospital with COVID-19.
I think one thing I want to kind of point out is this notion that the vaccine, RNA vaccine, will change your DNA. That's actually not true. If you think about the way genetics work, for us to change your DNA, so to speak, we'll have to take a DNA, insert that DNA into your own DNA for anything to even happen. Normally the way things work, DNA is transcribed to RNA. RNA gets translated to protein. So if you have blue eyes, there's a code on your DNA that codes for blue eyes. So your DNA just gets turned to RNA, then the RNA then gives you that blue eye. So RNA doesn't go back to DNA. The only way that can happen would be with viruses like HIV viruses. So normally it won't happen that way. So when we give you RNA vaccine, there's no way it's going to go into your DNA because it doesn't go that way. It goes forward. All it does is just make the protein, and your body responds to that and create antibodies.
Thank you so much, Doctor. I appreciate your time. I know you're at a conference in Miami, so we appreciate you taking time out of your day to talk with us. Thank you all to the viewers. We will have more on the COVID treatments options out there. We're going to have more on this tonight on our newscast at 11 p.m., so watch News Channel 5. Thank you all so much and have a great day.
Thank you.